Good morning, everyone. We're going to talk today about Section 11, endocrine and metabolic problems. And I have to go on record that I do not like the book's their PowerPoints. So there's a lot of information in endocrine and metabolic problems, and there's only 12 slides. So if you were just reviewing your slides for PowerPoints, you're not going to learn anything that you already didn't know. The previous edition's book had better slides, more detailed slides, but they will not link up, matching for tables and certain pages. So therefore, I'm going to make new slides. So here we go. Section 11 starts on page 875, and the first thing we're going to talk about is hypocalcemia. And we know that that is a calcium level that is lower than normal, and by the book's definition is less than 8.5. And when our bodies have lower calcium levels, there's an increase in the release of PTH, which is your parathyroid hormone, and this leads to calcium stores being pulled from the bone and increased absorption of calcium in the intestines. Some neuromuscular signs that can be associated with low calcium include Trousseau syndrome, which is a violent, painful contraction of the hands and feet. And then Chauvet's sign, which is a unilateral spasm of the facial muscle. We know that calcium is needed in the functioning of our heart, and its low numbers can be seen with symptoms in low blood pressure, bradycardia, CHF, and dysrhythmias. You can also see a prolonged QT interval seen on EKGs. Other symptoms include irritability, emotional instability, problems with memory. You can have paresthesias, fatigue, muscle cramps, generalized muscle weaknesses, and there can also be GI issues. Folks that have low calcium often complain of chronic constipation or diarrhea. If you have a patient that has a low calcium, other important labs to check would be magnesium, phosphorus, and albumin levels. As we mentioned when we first started, it's important to know what your PTH level is, and that can help to determine if this is a parathyroid condition. And then also it's important to get vitamin D levels. Depending on what the cause of the low calcium levels are, will determine what your treatment plan will be. Next, let's talk about gynecomastia, which is the enlargement of the glandular breast tissue in men, and it results from the imbalance of androgens and estrogens or an increased level in prolactin levels. It can affect anywhere from 12 to 40% of men in the U.S. and is present in about 60% of older men greater than 50 years old due to decreased testosterone levels. It may be an incidental finding on a routine exam and may present as an acute, one-sided or bilateral, painful, tender mass beneath the areola or as a progressive, painless enlargement of breast tissue. Gynecomastia can be associated with puberty and has an age onset of between 12 and 14 years. There are several medications that can be implicated in gynecomastia, and these include antiretroviral therapies in HIV infections, calcium channel blockers, tricyclic antidepressants, and SSRIs. As part of your differential diagnosis, you do need to consider, could this be a malignant breast tumor? But this typically is only in about 3% of all cases of gynecomastia. Mammogram would be the diagnostic test to confirm if there was concerns for a mass in this area, and then there's always the possibility of a fine needle biopsy that could be needed for diagnosis. Next, let's talk about hirsutism, and that's an increase in the terminal hair growth on the face, chest, back, lower abdomen, pubic area, axilla, or inner thighs, and it's present in approximately 5% of women. And almost a quarter of these women have increased hair growth on their face, especially on their upper lip. And it is caused by an increased secretion of androgens by the ovary or adrenal glands, or it can be an increased sensitivity to androgens, and this condition is often associated with menstrual irregularities. Approximately 90% of those that suffer from hirsutism, it's idiopathic or related to PCOS or polycystic ovarian syndrome, but there can be some serious underlying diseases that have to be ruled out. So it's important to get a targeted history. You want to know when the hirsutism was first recognized, how quickly it's progressed, get a detailed menstrual history, and get a review of all associated symptoms. When the cause is determined to be adrenal or ovarian, the patient will be referred to endocrinology for treatment. For these patients, for their lab evaluation, you're going to be checking free testosterone levels, androstenedione, total testosterone. There's a 17 hydroxyprogesterone urine, a 17 hydroxycorticosteroids, TSH, prolactin levels, luteinizing hormones, FSH, and then a DHEAS. Depending on what these levels are will indicate what the next step will be in your workup. It's also important to know that there can be a familial tendency to have hirsutism, and these are seen with women of Eastern European or Mediterranean descent. Also, hirsutism is noted in obese women who have increased androgen levels due to insulin-stimulated androgen production by the ovaries. For mild cases, this is managed with cosmetic therapy, such as chemical depilatories, bleaching, physical hair removal can also be seen for electrolysis or laser therapy to help with hair management. Next, let's talk about increased neck size. And this patient may present with the common complaint that the shirt collar has become too tight. These patients should be evaluated immediately for any difficulty swallowing or problems with breathing. Increased neck size may be caused by a mass or changes in the structure of the neck, and these could include lymph nodes, the larynx, the pharynx. The most common cause of increased neck size is an enlarged thyroid gland. And patients with an increased neck size may also exhibit sleep apnea, so that's something to pursue as well. A thorough history is important. These patients should be questioned about any history of thyroid problems or any recent surgeries, allergies, sinus issues, or any complaints of a headache. Some symptoms that they may have may include dysphagia, shortness of air, chest tightness, cough, or hoarseness, and any of these should be addressed. On physical exam, you're going to be looking for any swelling of the neck, whether it's focal or diffuse. Any focal masses may be enlarged lymph nodes that could be related to Hodgkin's disease, sarcoidosis, or a thyroglossal cyst, thyroid adenoma, or thyroid cancer. If the swelling is diffuse, you should consider venous distension related to CHF, Graves' disease, a thyroiditis, or even a sub-Q emphysema. Based on what your findings are, will determine how the condition is managed. You're going to treat for the underlying cause. Next, we're going to talk about the 3 Ps, polydipsia, polyphagia, and polyuria. Just to refresh our memory, polydipsia is excess thirst, polyphagia is excess eating before satiety, and polyuria is excess urination with excretion greater than about 3 liters per day. These 3 conditions are typically associated with diabetes, diabetes insipidus, a diuretic abuse, head trauma, or certain psychiatric disorders. On page 879, there is a figure which is a diagnostic reasoning algorithm for these 3 Ps, so I would encourage you to review that. When you're talking with these patients, it's important to get a good history, as we mentioned, of any head trauma, weight change, thyroid disease, hypertension, or any familial history of diabetes. You're also wanting to assess for any psychiatric illnesses. You need to get a good detailed 48-hour history for INO, and try to see what fluids have been consumed in the last 48 hours and try to get some characteristics of what their urinary output was. The patient should be assessed for dehydration and malnutrition. Vital signs should be taken, and labs, including chemistries, hemoglobin A1C, CBCs, albumin levels. As we mentioned, these three P's could be first associated with diabetes, so it's always important to assess their blood sugar levels. Next, we're going to talk about Chapter 57, which is on page 880, and we're discussing glandular disorders. And we're first going to start with hyperthyroidism, which is the excess secretion and synthesis of one or both of the thyroid hormones. And these are T3 and T4. And the book discusses thyroid toxicosis as a general term that encompasses hyperthyroidism as well as exogenous thyroid hormone intake and subacute thyroiditis, where you can have inflammation of the thyroid gland, and this can result in a rapid excretion of thyroid hormones. These patients can often have alterations in growth, metabolism, and development, and long-term effects of hyperthyroidism can include heart disease, osteoporosis in postmenopausal women, mental illness, and infertility. As we mentioned, hyperthyroidism can occur spontaneously from the overproduction of thyroid hormones, but it can also be caused by excessive intake of thyroid hormones. Graves' disease is one of the most common causes of spontaneous hyperthyroidism in the U.S. and is considered an autoimmune disorder characterized by autoreactive agonistic antibodies to the TSH receptors. And Graves' disease accounts for 80 to 90% of hypothyroid cases, and this condition peaks typically in young adults between the ages of 20 to 40. And it's also one of the most common forms of hypothyroidism seen in pregnancy. On page 881, we have a table that includes common causes, both common and rare, for hypothyroidism, so I encourage you to read that. With this increase in thyroid hormones, the excessive release of T3 and T4 into the circulatory system, this increases metabolism and can lead to an increase in the total heat body production. You can have increase in heart rate and contractility and vasodilation, and that's why with hyperthyroidism you may see palpitations, diaphoresis, heat intolerance, and anxiety. The clinical presentation is going to depend on the duration and the amount of excess thyroid hormones that have been secreted. On page 882 in table 57.2, there's a good description of each of the different bodily systems and how the patient may present subjectively and objectively based on hyperthyroidism. So be sure and review that. One thing to mention, though, is when I think of someone with Graves' disease, their eyes are one of the things that I seem to notice the most. So be sure and ask questions about, or make sure that your patients you're assessing if they've had any eye complaints, whether they've had blurred vision, proptosis, which is that downward look of the eyeball, if they have any double vision or any photophobia. When you're examining these patients, it's important to do a good examination of the neck and look for any visual enlargement of the thyroid and to palpate for any lymphadenopathy. In Graves' disease, you may find a goiter and it may be present as being firm. The thyroid in a multinodular goiter may be softer, but you may be able to palpate several nodules. In subacute thyroiditis, the patient may have a firm, painful thyroid gland with noted enlargement and may complain of fatigue and a low-grade fever. These patients may present with tachycardia, an irregular pulse, systolic murmurs, and a widening of pulse pressures. In the book, under the guidelines section, there is the most recent guidelines for the management of hyperthyroidism, so be sure and review that. Um, Know, though, that the level of thyroid hormones may not correlate to the clinical presentation for hypothyroidism, and your initial screening tests are going to include a TSH and also assessing for T3 and T4. In most cases of hyperthyroidism, the TSH level may be less than 0.35, and you'll see that with an elevated T4 level. Treatment of hyperthyroidism will be dependent on the cause and the patient characteristics. The goal is to have a euthyroid state, meaning a proper balance, while minimizing any adverse effects. Emergency treatment may be necessary if the patient presents in a thyroid storm, and some more details about a thyroid storm are found on page 884 in table 57.3. Treatment can include antithyroid drugs, radioactive iodine, or surgery. And the most successful treatment in achieving a permanent euthyroid state is surgery. However, it's rarely the preferred method of treatment unless the thyroid gland is extremely enlarged and is pressing on other structures of the neck. These patients may experience tachycardia, palpitations, and tremors, and may benefit from a beta blocker during the initiation of treatment. And beta blockers provide effective short-term relief of this hyperadrenergic symptoms, but you have to be cautious that beta blockers are contraindicated in patients with COPD, bronchospasms, or uncompensated heart failure. There are two medications that are commonly prescribed for hyperthyroidism, and you can find those on page 886, and that includes both PTU, which is propylthiouracil, and then MMI, which is a methimazole. And these are the drugs that are recommended for treatment of hyperthyroidism in pregnancy, especially PTU. Another treatment option is radioactive iodine, I-131, and of course that would be overseen by radiation oncology, so we're not going to get into that. And then another option is surgery, which of course would be performed by the surgeon. So be sure and read up on that on page 887. The goal of follow-up is to manage the hyperthyroidism, any complications, provide referrals and schedules to check on labs and management of medications. All patients that have been diagnosed with Graves' disease should be referred to ophthalmology for a full eye evaluation. And follow-ups are going to be dependent on the choice of treatment and the patient's response. And when you do check labs, you're going to be following TSH and a T3 and T4 levels, as well as checking blood pressure and pulse, weight, which are characteristics of how well the thyroid gland is doing. Next, let's talk about hypothyroidism, which is a slow progressive disease of thyroid hypofunction. It can lead to inadequate amounts of the thyroid hormone being produced or secreted and results in slowing of many bodily functions and metabolic processes. On table 57.4 on page 890, there are causes of hypothyroidism listed, whether it's loss of functional thyroid, and those causes biosynthetic defects in the production of in thyroid hormone production, whether it's central hypothyroidism or transient hypothyroidism. So be sure and review those on page 890. These patients, their symptoms may vary dependent on their age, the duration of illness, and the severity. Regardless of the type or the cause, symptoms are very similar. They're often subtle and nonspecific. Some classic symptoms include fatigue, dry skin, slight weight gain, constipation, cold intolerance, and heavy periods. You can have myalgia and muscle cramps, headaches, weakness. Later symptoms may include dry skin, coarse hair, loss of outer eyebrows, hoarseness when talking, continued weight gain, decrease in mental abilities, depression, decreased libido, and hypersomnia. Because symptoms can be subtle, it's important to do a good review of systems and focus on the areas that may be impacted most by hypothyroidism. Physical exam should include a general overall appearance of the patient, noticing any slow movements. You want to assess for their hair, if they have any thickened tongue. You want to assess their thyroid, noting if there's a goiter or if there's any a thyroid is non-palpable. Their heart may have some hypertrophic tendencies, and the PMI may be laterally displaced. These patients typically have bradycardia. They may have facial puffiness, periorbital edema. We talked about the dry, thick skin and dry, coarse hair. They may have slow speech. Um, they may have pitting edema of the lower extremities. On page 892, table 57.5 gives clinical presentations for hypothyroidism, and as it was with hyperthyroidism, it's broken down into bodily systems that are impacted in hypothyroidism, subjective findings and objective findings. So I encourage you to review those. Recent guidelines do not recommend routine screening of asymptomatic women before the age of 50. But many clinicians still use the age of 40 as their criterion. In the Blackboard section under guidelines, there is the latest guidelines for hypothyroidism, so I would encourage you to review that. The diagnosis of hypothyroidism is made by the measurement of TSH, and then TSH and T4 should be used to monitor treatment. Primary hypothyroidism is associated with a low T4 and an elevated TSH. The goal of thyroid hormone replacement in primary hypothyroidism is to normalize and not suppress the TSH, and there is always the risk of overtreatment with suppressed TSH, particularly in postmenopausal women. There can be decreased bone mineral density after several years that can lead to osteoporosis. Replacement will be with a synthetic L-thyroxine, and more about that medication is found on page 894. But the guidelines, when calculating a dose, the guidelines by the American Association of Clinical Endocrinologists recommend the usual dose of 1.6 micrograms per kilogram per day for full replacement, and you can adjust that based on the patient's age and how well you think that they might respond. But regardless of the replacement therapy, all patients should be monitored for signs of thyroid toxicity, especially any chest pain or arrhythmias. If there's any difficulty in regulating an appropriate dose for the patient, then referral to an endocrinologist is recommended. In regards to follow-up after therapy has been initiated, the patient should be monitored to see the impact of treatment about 4 to 8 weeks by evaluating the TSH level. At that time, the TSH level should be anywhere from 0.3 to 2.4. And then, if necessary, you can increase the levothyroxine dose more at every 6-week intervals to achieve the level that you desire. Once you're able to get stable lab levels, you can check labs biannually or yearly. All right, we're going to talk about thyroid cancer, and that'll be the last part of this section. Then we'll come back and start again with Cushing's. But for thyroid cancer, it's the most common endocrine-related cancer. Subjectively, these patients may complain of a lump or a nodule in the neck, which is usually painless. They may complain of a tight or full feeling in the neck, difficulty swallowing. They may have hoarseness or have hemoptysis. Malignant neoplasms of the thyroid are most likely fixed and non-tender and firm and may have an irregular shape, but the only true way to diagnose any cancer is to have a biopsy. When you're evaluating concerns for a thyroid cancer, you're going to want to do an ultrasound to identify for any thyroid nodules, and a fine needle aspirate biopsy is usually successful in differentiating between a benign or cancerous lesions. However, if fine needle aspiration may not capture all of the cases, and a repeat biopsy may be needed. The sensitivity, though, of this biopsy is improved if it's done with an ultrasound guided technique, so that your radiologist is able to get into the nodule. These will be patients that will be referred to your endocrinologist, and early referral decreases cost, patients' time in the hospital, and improves the precision of diagnosis. So we will end part 1 on this note and come back for Cushing's disease. Thank you.